Welcome back to part 2 of chapter 28 and toxicology. We're going to pick up right where we left off, and that discussion is going to start with the topic of marijuana and cannabis compounds. Of course, marijuana and cannabis compounds have become increasingly popular with all of the new laws that allow for their use, whether that's for medical use or medicinal or, just free reign. It's differing from state to state, and more states are allowing it, although the federal government still sees it as a controlled substance. So cross state lines with it and you're going to be in big trouble. Marijuana comes from the cannabis plant. Hashish is created using the resin collected from the flower tops of the plant. There is still an ongoing debate about both the legalization of marijuana and its use in medical treatments. A lot of that has been going back and forth for years, and the debate continues. It contains a variety of chemical compounds that have different effects on the body. One of them is CBD. This one provides therapeutic benefits without causing any kind of intoxication. It's been found to be helpful with managing pain, supporting mental health, and treating things like certain forms of epilepsy. THC is the compound that causes the high or the euphoric feeling associated with marijuana use. Since CBD doesn't contain a high, it has been approved for medical use in some states, especially in the form of high CBD strains or oils. The main psychoactive component, as mentioned, is that THC. It's this delta-9 tetrahydrocannabinoid, if you want to get technical with it. THC interacts with the cannabinoid receptors in the brain, which leads to changes in perception and behavior. Marijuana can produce feelings of euphoria and enhance sensory experiences. However, it may also cause some anxiety or panic in some individuals. Short-term effects include rapid heart rate, impaired coordination, issues with balance, and an increase in appetite. Other common effects are red eyes, dry mouth, memory problems, drowsiness, and an overall sense of relaxation. Long-term use can lead to respiratory symptoms like cough, although usually it does not result in the kind of airway obstruction that we typically see with tobacco smoking. Marijuana can be smoked, vaporized, eaten, insufflated, and applied to the skin. When inhaled, it produces rapid effects such as euphoria and relaxation and impaired cognitive and motor functions. Marijuana intoxication as well as withdrawal are rarely life-threatening issues. In most cases, emotional reassurance and supportive care are all that is needed. New or inexperienced users may feel anxious or panicked or paranoid due to the changes in perception. These reactions are best managed by creating a calm environment and offering reassurance. If the anxiety is severe, then benzodiazepines may be indicated. Severe symptoms could be a sign of other substances were involved as well, which is not uncommon. Always keep in mind the possibility of a polydrug exposure when there's marijuana involved. Some individuals, especially children, may not realize that they've consumed cannabis. Often, though, the edibles or like brownies and gummies are how they wind up consuming these, and they just don't know that that's what's in them. Children are more sensitive to cannabis and may experience serious effects. Edible ingestion in kids can cause extreme drowsiness, slow breathing, or even seizures. In these cases, it's important to call poison control and give IV support, as well as arrange for immediate transport to the hospital. There is something called cannabis syndrome, which occurs in people who use marijuana regularly over a long period of time. It causes repeated episodes of nausea and vomiting, and treatment usually involves IV fluids and anti-nausea medications, especially during transport. Spice, on the other hand, this is a synthetic version of a cannabinoid, and it's part of a broader group known as the newer psychoactive substances. Although it's often labeled as synthetic marijuana, It's chemically different and tends to be much more potent and dangerous than your typical marijuana. It's commonly sold as either dried plant-like looking material meant for smoking or as a liquid to use in vapes and e-cigarettes. Some users report a high that feels similar to THC, but the effects are far less predictable. Compared to natural cannabis, the intensity and variability of reactions are often much greater. Use of spice can lead to serious side effects including psychosis, hallucinations, rapid heart rate, vomiting, kidney issues, and seizures. Spice often contains a mixture of unknown and unregulated chemicals, which means the symptoms and severity can vary widely from one person to another. Supportive care is going to be the mainstay of treatment with these patients. This includes IV fluids, anti-nausea meds, and of course, if a seizure occurs, they should be treated with benzodiazepines according to protocol. Hallucinogens are substances that alter perception, impair judgment, and can cause users to see or hear things that aren't actually there. These effects can vary widely, even for experienced users. Several factors influence how someone responds to hallucinogens, including their past use, the dosage they've taken, and the setting in which the drug is used. There are two main categories of hallucinogens, the first one being synthetic. This includes things like LSD, PCP, and ketamine. And then there are some natural occurring hallucinogens such as mescaline and psilocybin, as well as jimsonweed seeds. LSD, of course, is a powerful hallucinogen that is synthesized from a fungus commonly found on contaminated rye and wheat. It is usually taken by mouth and is often sold as tablets, capsules, or drops in a blotted on paper. The effects typically begin within 30 to 60 minutes after ingestion. A single LSD experience can last anywhere from 8 to 24 hours, depending on the dose and the individual. LSD actually causes significant changes in perception, mood, and one's sense of reality. Some users experience instances where the senses overlap, such as seeing sounds or hearing colors. Even a small dose can produce strong effects, especially in people who are trying it for their first time. Larger doses tends to intensify and prolong the experience. Although tolerance to LSD can develop quickly, it does not usually lead to physical dependence or withdrawal symptoms. LSD activates the sympathetic nervous system, which can cause mild tachycardia, palpitations, dilated pupils, and sweating. In some cases, users may experience a bad trip marked by frightening hallucinations and intense anxiety that lasts until the drug wears off. The primary approach to managing LSD intoxication is going to be supportive. If the person is experiencing severe anxiety, benzodiazepines or something along those lines may be administered if your protocol is going to allow that. During transport, it's important to reduce external stimulation by minimizing light, noise, and other sensory input. This can help keep the patient calm and prevent further agitation, because these patients can go off the deep end really, really quickly, and sometimes they have an extraordinary amount of strength. Not quite as much as PCP, but PCP is known by the street name like angel dust, rocket fuel. It's a dissociative anesthetic with powerful hallucinogenic effects. It was originally developed in the 50s as an IV anesthetic, but it's no longer used medically in the United States due to its severe side effects. Can you imagine going in for a procedure and they give you PCP? PCP is typically found in a powder, crystal, or tablet form and is sometimes used laced in marijuana. That's why it's not unusual to have a co-drug issue sometimes with marijuana. It's also commonly mixed with other street drugs to boost their potency. PCP acts by acting on the NMDA receptors in the brain, and it disrupts normal brain function. It alters perception of sound and sight and creates strong sense of detachment from one's own body and the surroundings. It's usually smoked or snorted, but it can be injected. And even in small amounts, as little as 5 to 10 milligrams, can lead to intoxication. Symptoms are going to include slurred speech, unsteady or staggering gait, rapid heart rate, high blood pressure is common. They can also have that vacant or blank stare, that 1,000-yard stare, and maybe even some nystagmus. Muscle rigidity and teeth grinding is not uncommon. And in some cases, some users may display remarkable feats of strength, and they might seem impervious to pain. And this may lead them to continue to act aggressively and erratically, even after sustaining serious injuries. These are the ones that get the most scary, is when they really get wild on PCP. It's important to realize that PCP use can result in violent and erratic, unpredictable behavior. So patients may display rapid mood swings and become suddenly aggressive. So your scene safety is of paramount importance. Make sure that you ensure your safety and the safety of your team at all times. If the patient is combative or poses a threat, we can give sedatives if possible, if your protocols are going to allow that, but realize it probably is going to involve a larger influence of law enforcement and some other people involved in that if it's going to come to that. Supplemental oxygen if the patient will tolerate it and they show signs of respiratory compromise. Watch their vital signs and keep an eye on them throughout care because of their tendency to have high blood pressure, tachycardia, and those things. And then, of course, you want to make sure that you give them a safe, secure transport to an appropriate medical facility so they can further evaluate that patient and treat them. Unfortunately, there's not a whole lot of treatment for either one of these last two. Generally speaking, they're just going to have to wear off over time. It's just going to be up to that drug wearing off. Ketamine is a dissociative anesthetic, but it's short acting. It's used both in the medical and veterinary settings for various procedures. In the pre-hospital setting, ketamine is commonly used for procedural sedation, managing agitation, or for violent behavior, and to some degree even controlling pain. Sometimes it's mixed with other illicit drugs to intensify its effects and the effects of the other drugs. Ketamine primarily works by acting on those same NMDA receptors in the brain. It also binds with opioid receptors as well, which contributes to its pain-relieving effects. At low doses, users may feel mildly intoxicated, experience some euphoria, and become more sociable. However, at higher doses, users can experience intense symptoms like nausea, difficulty with movement, and strong hallucinations. Violent behavior is much less common with ketamine than it is PCP, but it is still possible. First, ensure that the patient is secured and safe and prevented from harm, and then make sure that you and your team are safe and maintain that safety levels. Assess the ABCs and make sure that that remains a priority in your care. Give oxygen as needed in order to maintain the adequate oxygen levels. If the patient is cooperative, establish an IV for medication or fluids. And of course, we want to make sure that we take them to a facility that can continue to evaluate and ultimately treat them. If the patient is severely agitated and experiencing delirium, benzodiazepines may be helpful in calming them down, but more than likely you're going to have consult medical control before you're able to move forward with that. Peyote has been used for thousands of years by native tribes in the southwestern United States and Mexico, and this is primarily for spiritual and ceremonial purposes. The exact mechanism of how it works is not fully understood. Of course, it's a dried flower button that can either be eaten directly or soaked in water to create a mescaline-infused liquid. It produces a psychedelic experience that typically begins with heightened sensitivity to sensory stimuli such as flashes of color and a disoriented sense of time and space. Users also state that they kind of have an out-of-body experience with hallucinations that can be influenced by the user's environment. Physical effects might include dilated pupils, increased heart rate, mild hypertension, and an elevated body temperature. Pre-hospital care for peyote or mescaline intoxication is mainly focused on supportive measures. We want to give supplemental oxygen if necessary to maintain those oxygen levels, monitor the vital signs throughout care, offer reassurance and emotional support as needed to try to keep the patient calm and alleviate that anxiety, and of course arrange for safe transportation to an appropriate facility for further care. If they experience nausea or severe vomiting, consider administering fluids and antiemetics to help kind of manage those symptoms. Mushrooms, psilocybin mushrooms contain 2 hallucinogenic substances. The most common misused species are the Mexicana and the cyanesins. These mushrooms typically have a bitter taste, which is often masked by mixing them with liquids or other foods, so they'll mix them. Symptoms and hallucinogenic effects usually begin in about 30 minutes after ingestion, and the effects typically last between 4 to 6 hours. Symptoms you're going to see is muscle weakness, drowsiness, nausea, vomiting, tachycardia, some hypertension. Although the risk for serious adverse effects is generally low, there have been reports of seizures and hyperthermia with the use of mushrooms. Mushrooms is another one of those that's similar to marijuana that is beginning to see more and more legalization of it, for non-medicinal purposes. So it's becoming more and more commonplace in some ways. So the likelihood of you as an EMS provider running into instances where this is used is becoming more and more likely. So our main focus of care is going to primarily be supportive. Hallucinations usually subside quickly when the patient is in a calm and supportive environment. So be sure to watch the ABCs, continuously monitor vital signs and track changes in the patient's condition, and ensure that we take them to an appropriate facility for further evaluation and treatment. If time and circumstances allow with these patients, go ahead and start an IV for potential medication or fluid administration along the way, because it could be beneficial. So sedatives and hypnotics are a group of drugs that have a variety of medical uses and well-established therapeutic benefits. These drugs act as central nervous system depressants and can provide a wide range of effects. So the sedative side of things, these drugs actually help reduce anxiety and calm agitation. We've been talking about one of them for a while, and many of these as we've went through, and that's benzodiazepine. It's one of those that's a potent and effective sedative, or benzodiazepine as a group of those medications that do that. And then we have the hypnotics that are commonly used as sleeping aids. However, sedatives and hypnotics also have a high potential for misuse and abuse, so they're commonly used improperly. One of them that used to be used medically a lot that is not used so much anymore are barbiturates. And of course, these are central nervous system depressants that have a range of therapeutic uses. They are still prescribed as anxiolytics or anticonvulsants and hypnotics. They're clinically similar to alcohol, especially when it comes to dependence and withdrawal symptoms, which is what's made them less favorable for some of the newer medications that's out there. Unfortunately, they're sometimes combined with alcohol in suicide attempts due to their depressant effects. These barbiturates, they work by enhancing the effects of the gamma aminobutyric acid, or GABA, at specific receptors, which inhibits excessive brain activity and reduces cellular excitation. So it just kind of brings everything down. They come in 4 basic types based on the duration of acting. of the way that they act. Of course, ultra short acting, these are the ones that are highly lipid soluble, and they have a rapid onset of action, but they don't last real long because they're really lipid soluble. They're taken up quickly. And then we have short acting, intermediate acting, and long acting. And of course, the long acting, as you would imagine, are less lipid soluble, and they have a delayed onset and a longer duration. So it takes them longer to hit, but when they do, they'll last a whole lot longer once they're there. Mild to moderate intoxication of barbiturate looks similar to an alcohol intoxication, with symptoms include decreased alertness, nystagmus, ataxia, mental confusion, slurred speech. As that dose increases, the level of central nervous system depression worsens, and the patient may become increasingly lethargic, eventually reaching the point of unconsciousness. It's important to be aware of the risk of respiratory depression, which can be life-threatening in severe cases and fatal if not treated. So make sure to closely monitor the patient's airway status to ensure proper breathing. It's important to keep track of pulse oximetry and capnography in these patients to assess the levels of oxygen and carbon dioxide production so we can see what's happening at the cellular level as well. Signs of shock, if signs of shock are present, of course, provide fluid support with crystalloids in 250 ml increments up to about 2 liters. Perform frequent evaluations of lung sounds to ensure pulmonary edema is not developing. If the patient has received adequate fluid replacement but hypotension persists, consider administering a vasopressor, and we probably should be looking at some other potential causes as well. If you're treating a conscious patient within 1 hour of ingestion, you may want to consider administering activated charcoal, but only if the patient is able to maintain their own airway. For long-term users, sudden cessation of barbiturates can lead to withdrawal symptoms within about 24 hours. Minor withdrawal symptoms are going to be similar to what we see in withdrawals from alcohol: restlessness, trembling, insomnia, sweats, abdominal cramping, nausea, vomiting. Severe symptoms are going to get up there to delirium, hallucinations, psychosis, cardiovascular collapse, and even up into life-threatening withdrawal that's similar to delirium tremens that we see with alcohol withdrawal symptoms. To prevent seizures and cardiovascular collapse, ensure rapid transport to an appropriate medical facility so that the treatment can begin and to hopefully stave off some of those things. Benzodiazepines, we've talked about these, or at least they've been mentioned so far, are a part of these sedative hypnotic family of drugs. They're commonly used to treat conditions like anxiety, seizures, withdrawal symptoms, all those kinds of things that we use in the pre-hospital, or seizures especially we use in the pre-hospital setting. Fast-acting benzos, such as Ambien, are often used to treat insomnia due to their ability to help with sleep. Benzos work by stimulating that GABA pathway in the brain, which leads to sedation, reduced anxiety. When administered intravenously, benzos provide a fast onset of action and allow for more controlled dosing. If a benzodiazepine is indicated for a patient, follow your local protocols for administration and dosing. Ensure that you assess any potential adverse reactions and monitor the patient accordingly, for those side effects. An overdose generally has a low morbidity and mortality rate when it involves a single drug. So if it's just one benzodiazepine like Valium or something along those lines, they have a pretty low morbidity and mortality rate. The most common clinical effects of an overdose we'll see is altered mentation, drowsiness, confusion, slurred speech, ataxia, and a general loss of coordination. In cases of overdose, it's important to be aware that there may be the possibility of multiple substances involved, because that's typical of overdoses. Withdrawal from benzos is rarely life-threatening, but can include symptoms like tachycardia, shaking, confusion, and seizures. For treatment decisions, follow your local protocols for assessment and management of these patients. Assess and manage the patient's airway to ensure proper breathing. give supplemental oxygen as needed, start an IV for fluid or medication administration, monitor their heart rate by placing an EKG on them, though they're not at a real high risk of dysrhythmias. Pulse oximetry capnography is a good idea, so you can kind of measure the onload and offload of oxygen versus CO2. If the patient is hypotensive, give them a fluid challenge, or consider it at least, to improve that blood pressure. If necessary, consider administering a vasopressin to support blood pressure if you're having trouble getting that under control. If within an appropriate time frame the patient is conscious, consider administering activated charcoal, but only if that aligns with your protocols and the patient's able to easily maintain their own airway. Of course, you need to ensure safe transport to an appropriate medical facility for further evaluation and care. And make sure that you document all of those treatments and follow your protocols accordingly whenever you're treating these patients. Opioids also act like central nervous system depressants and produce insensibility and stupor. They're classified into natural products derived from opium in the poppy plant, or synthetic products designed to produce similar effects, and there is a lot of the synthetic ones out there. In recent years, potent drugs like fentanyl and desomorphine have increased on the streets, and these things have a potency level unlike anything imaginable. Pre-hospital providers have seen a significant rise in opioid overdoses since the year 2000, and that continues to be a big problem today, especially fentanyl. The FDA has approved auto-injectors that deliver IM Narcan to help reverse opioid overdoses, and these are pretty common and readily available to people in the public as well as firefighters and law enforcement officers. So it's important that we ask that question and find out if Narcan has been administered before the arrival of EMS. So it's always a good idea to ask it if it has been administered. Not that it's going to be a huge change to your treatment plan, but it's knowing whether or not it's been administered is going to be helpful. The risk of addiction or misuse should not influence your decision to treat acute pain in the pre-hospital setting. So don't hold back on using opioids to treat pain in the pre-hospital setting because of the concern out of addiction or misuse. However, some patients that are former addicts may refuse to have that, so it's important to make sure that they know what you're giving them so that they have an opportunity to refuse that. Many addicts will refuse it. So the way these things work is they'll bind to three main opioid receptors. They're the delta, kappa, and mu. It literally sounds like a sorority, the delta, kappa, and mu. These receptors can produce both analgesia, or pain relief, and euphoric sensations. They can be ingested, insufflated, inhaled, injected, or transmitted transdermally through patches. When taken orally, the effects are lessened due to the first pass metabolism. Basically, it's kind of the liver gets a chance to kind of break it down before it reaches the bloodstream, so the liver does a little filtering. Common opioids used by EMS for pain in the pre-hospital care setting include morphine and fentanyl. That list is changing all the time. We don't see morphine on there as much. We actually see fentanyl, ketamine, and some other things on there just because of their availability and the dosing. Classic presentation of opioid intoxication include euphoria, hypotension, respiratory depression, and pinpoint pupils. Typically, it's not the patient that's calling us about this. They're having a good time. It's somebody else. But some may actually cause nausea, vomiting, and constipation as well. High doses may lead to coma, seizures, and even cardiac arrest. Morphine and heroin are very closely related, and they can both produce this kind of dreamlike state. So the users may appear unconscious, but still be pretty lucid and aware of what is going on. They still hear and respond to everything that's going on around them. It's kind of weird. Management should focus on establishing and maintaining a patent airway and ensuring the patient's ventilatory status is adequate and remains so. get an IV. We might need to administer Narcan, but remember, we're going to administer Narcan in those cases where it's much more extreme. Just because they look like they're slightly or mildly intoxicated is not when we're going to give that. We're going to give Narcan in those cases where there's respiratory compromise, there's legitimate issues with their survivability, and be cautious in giving that too, because giving too much of it will bring them too far out of it, and you may have a fight on your hands. They may get very, very angry with you for bringing them out of it. If they don't respond, they may have ingested a potent or large dose of that opioid. This is becoming increasingly true with the fentanyl that's out there nowadays. There's large doses of fentanyl that is out there that people are getting their hands on and inadvertently taking a dose, in one pill that is a fatal dose for 100 people. You're not going to have enough Narcan on your truck to reverse the effects of that. These people they're going to die because of an overdose, and it's arguably less of an overdose and more of a poisoning, and probably borders on murder, as opposed to just drug use. So. Of course, realize that the coma could be from another cause as well, such as a stroke or polypharmaceutical overdose of other medications or other drugs that may be on board, as opposed to just an opioid. So here's the algorithm that we're going to follow when we're taking care and treating opioids. And I apologize that it's a little blurry, so it's a little hard to read. But this is that we're going to follow and kind of go down this progression chart to treat them. If they're breathing normal, yes, then we're just going to tap and shout. We're going to kind of do that kind of thing. If they're not, and they have a pulse, that's when we're going to start doing, giving Narcan, supporting the airway. If they don't have a pulse, then we're going to go down that CPR algorithm. And then when we get to our H's and T's in that CPR algorithm, that's when we're going to look at, treating that opioid thing. Or if we know that it is, we can begin treating that early on in the CPR process as well. So another one of the categories that is a biggie is these cardiac medications, because they can have severe effects on the body when they reach toxic levels. The major classes of these drugs, of course, are going to include those antidysrhythmics, beta blockers, calcium channel blockers, cardiac glucosides, and angiotensin converting enzyme inhibitors, or ACE inhibitors as they're commonly called. Overdoses of cardiac medications are almost always unintentional. And realize too that a single pill or tablet of many of these medications can create a life-threatening situation, especially for small children and infants if they get their hands on these. And they rarely take one. They pop them like, M&Ms or something. So assess and manage these patients should include getting a really good patient history and a medication list. This information actually is going to help identify which substances are involved in the overdose, or that's the hope, and if they're taking any other medications that may worsen the effects of that particular one. Accurate identification is critical because many standard treatments may be ineffective, especially if the medication has not reached toxic levels. So knowing what it is gives a chance for that medication to be reversed, or for other medications to be given so that some of those effects can be lessened. A lot of these happen with elderly patients who've forgotten that they've taken their medications and they've taken them again, and they'll give you a call. So sometimes this happens before they've even started having symptoms. And when this happens, they've taken their regular dose and then they wind up taking it again accidentally, and it could be 5, 6, 8, 10 different pills, who knows, that they've doubled the dose on. This is when you really need to contact poison control and probably medical control early on, and they're going to tell you what to do. They may say to administer activated charcoal if you're in that first hour of ingestion, or they're going to tell you to transport and watch out for these things. Some of these medications also are extended release medications, and in those instances, even after that first hour, activated charcoal may be considered or may be recommended. Really, the best course of action is going to be to reach out to poison control for some helpful advice, but you're going to need to have those very specific medications handy, the names of those, the doses, and how much they've taken of each one. The first one we'll talk about is the sodium channel blockers, and this is your like your lidocaines. They can lead to QRS prolonging, QT prolonging, hypotension due to the decreased myocardial contractility, and vascular dysrhythmias. These are less common than some of the other meds out there, but there still are some sodium channel blockers out there that are being taken. Beta blockers, a very common one. There's lots of different kinds of these. They'll present with hypotension, bradycardia, may have some symptoms like lethargy, weakness, shortness of breath. They may even be hypoglycemic, and this is especially true in those pediatric patients. Bronchospasms are not uncommon either in patients with those reactive airway diseases. Consider atropine for symptomatic bradycardia, fluids for hypotension, and keep an eye out for seizure activity, and we're probably going to have to throw a benzodiazepine in there if they begin having seizures. Potassium channel blockers may present with hypotension, bradycardia, and some ventricular dysrhythmias. One of the primary effects seen on the EKG is this prolonged QT interval, and we might see some very peaked or pointed T waves. Treatment for acute potassium channel blocker toxicity is mainly supportive, but IV mag sulfate may be used to treat torsades if torsades shows up during cardiac arrest, and that torsades would be an indication that the patient needs magnesium sulfate, because that's the routine treatment for torsades. Calcium channel blocker toxicity will typically show up with a decreased pulse rate, decreased AV nodal conduction, decreased myocardial contractility, vasodilation, nausea, vomiting, altered mental status, and metabolic acidosis. This calcium channel blockers is used to treat things from high blood pressure to heart failure. So it's used out there a lot more commonly than people realize. Calcium chloride or calcium gluconate is going to be the initial treatment. So basically you're just going to kind of overload the amount of calcium in the body to counter the effects of the calcium channel blocker. Glucagon may help to improve both the pulse rate and the myocardial contractility. Of course, administer fluids 20 mils per kilogram if there's signs of hypoperfusion. And you may have to consider a vasopressor if that hypotension is persistent after you've administered a fluid resuscitation. Cardiac glucosides like digitoxin can be really challenging to keep within a therapeutic range. So patients often struggle with that. So it's not one of the more ideal drugs, but it's still used out there, for patients, at home. Acute digitoxicity may present with nausea, vomiting, GI distress, and lethal hyperkalemia. This is, we'll see all those hyperkalemic things. The definitive treatment for acute digitoxicity is this digoxin immunofab, which is called Digibind. Typically administered in a hospital setting. I think it's always pretty much administered in a hospital setting. It's not administered by medics in the field. But Digibind, basically it takes up or it grabs a hold of that dig so that it can't do what it does to the body. For us in the field, we might be able to give calcium gluconate that might help to some degree, but due to the complexity of cardiac drugs and other possibility of polypharmacy, it's important to contact medical control. The knee-jerk reaction might be that you want to just try to treat that hyperkalemia, and that may be appropriate, but reach out to medical control and touch base with them, because if dig is part of the role in this, if that's what's causing this, they may want you to go a different route. So be prepared for that and reach out to medical control when you're dealing with these. Okay, so organophosphates may be the last one we talk about in this one. I don't remember, but yeah, I believe it will. It'll probably be the last one we talk about in part 2. So organophosphates are key ingredients in many insecticides used in both commercial agriculture and in homes. They were developed in the early 1900s, so they've been around for a while, and they aim to reduce the food import dependence. So the early exposure, so the idea is that we could use these organophosphates to, kill off the bugs so that our crops would do better and we wouldn't have to import as much. So, but early exposure to these insecticides caused serious adverse effects, leading to their use as chemical weapons. So once they found out, oh man, these things really mess people up, so we're going to use them as chemical weapons. So basically, organophosphates are acetylcholinesterase inhibitors. So they block the acetylcholinesterase, and then we start to see the effects of that, which typically is going to be those effects that we see with stimulation of the parasympathetic nervous system. So examples of these medications are spectracide, otherine, other nerve agents such as sarin and V agent and those kinds of things. So there's some out there that are still commonly used, organophosphates for insecticides. Ironically enough, what it does to bugs, it'll do to us too. So common exposures to these might include attempted suicides via ingestion, accidental exposure in agricultural use, or exposure during the manufacturing process of these chemical agents. These exert their effects on the nerve cell junctions within the autonomic nervous system, specifically the parasympathetic side. Symptoms are consistent regardless of how the exposure occurs, whether that's ingestion, inhalation, or absorption. However, ingestion tends to delay the effects or delay the symptoms. Inhalation, on the other hand, leads to nearly immediate response and immediate symptoms. The mnemonic dumbbells can help identify the common overdose symptoms. So that dumbbells mnemonic stands for diarrhea, urination, meiosis or constricted pupils, muscle weakness, bradycardia, bronchospasms, emesis, lacrimation or tearing of the eyes, and then of course seizures, salivation, and sweating. So those symptoms, those things that we would expect to see from an overstimulation of the parasympathetic nervous system is what we're going to see with this, and that's why atropine works, because atropine, remember, is that parasympatholytic. It's going to try to block the parasympathetic side, so atropine does work well with organophosphates. In moderate to severe poisonings, the symptoms may also include muscle facilitations, severe respiratory distress, seizures, and even flaccid paralysis. Decontamination, of course, is always going to come first, and it's going to be performed by the hazmat team. And then we're going to position the patient in a lateral recumbent position if possible to enable drainage of those secretions and prevent aspiration, because that's a real concern. Establishing and maintaining a solid airway is really, really important. And we're going to have to suction as needed, provide oxygen to keep the O2 sats at 94 or higher, get an IV started, administer atropine either by IV push or auto injector, and repeat until symptom reversal occurs. It may be that you go through a lot of atropine. It's not uncommon to go through milligrams and milligrams of atropine if it's a large exposure. There is also the PAM2 or 2 PAM kits, which it concurrently gives atropine with it gives 2 it gives another medication along with atropine, and that is typically given within the first hour of exposure to organophosphates. Put them on EKG, pulse ox, and capnography. Inform the receiving hospital as soon as possible to ensure that their patients transported immediately to an appropriate facility that can manage them. Atropine is going to be the main antidote for poisonings in these, because that acetylcholinesterase inhibitor is going to stimulate the parasympathetic nervous system, whereas atropine is going to suppress the parasympathetic nervous system, so it'll fight it off. Use benzodiazepines to manage seizures if those rear their ugly head. All right, so part 2. That is part 2. We'll pick up in part 3 coming up in the next section. I do not remember where it starts off with, but we'll see everyone back at part 3.